You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about CABG revascularization. We will cover topics that are important to know from a cardiology standpoint, including choice of conduit vessel for CABG, choice of CABG versus PCI as a revascularization strategy in chronic coronary disease, pre-CABG management, and post-CABG management. We'll start with choice of conduit vessel. First of all, how do you decide between an arterial and venous graft? Arterial grafts have better long-term survival than vein grafts, with a 90% patency rate at 10 years, whereas vein grafts will deteriorate within 5 to 7 years in 50% of patients. In fact, vein graft occlusion occurs in 10% of patients before they leave the hospital. By 1 year post-CABG, 15 to 30% of vein grafts become occluded. The 5-year patency rates are for an internal mammary artery, 95 to 99%, radial artery, 82%, for a gastroepiploic artery, 70%, and for a saphenous vein, 50%. These are the 5 to 10-year patency rates. Internal mammary artery grafts are superior to vein grafts due to several reasons. First, the medial layer of arterial grafts may derive additional nourishment from the vasa vasorum, which vein grafts are not privy to. Second, the endothelium of the internal mammary artery produces high levels of endogenous vasodilators such as nitric oxide and is less susceptible to damage compared to the endothelium of vein grafts. Third, the diameter of the internal mammary artery is closer to that of the recipient coronary artery than is the diameter of the saphenous vein. Because arterial grafts have high production of nitric oxide and their endothelium is less susceptible to damage compared to that of vein grafts, arterial grafts result in fewer reoperations, lower MI, and less recurrent angina than vein grafts. Vein grafts tend to be stenosed at a faster rate if the patient is smoking, has hypertension, hyperlipidemia, or diabetes, compared to if they didn't have those factors. However, arterial grafts do require more dissection to get to, so it is difficult to use in emergency situations. Among arterial grafts, lima, the left internal mammary artery, is the artery of choice. Among venous grafts, the saphenous vein is the vein of choice. The phases of vein graft failure are early, within hours to less than 1 month, it happens by thrombosis. Intermediate, within months, happens by intimal hyperplasia. Late, more than 12 months, happens by atherosclerosis. Aspirin 81 milligrams daily lifelong and lipid-lowering therapy are used to reduce the development of graft disease. When a graft is placed to bypass a native artery lesion, the native artery's atherosclerotic disease accelerates 3 to 6 times compared to the ungrafted native arteries. Therefore, arteries that have minimal atherosclerotic disease should not receive a bypass graft. Let's focus now on the left internal mammary artery. The lima, also sometimes called the lita, L-I-T-A, T for thoracic, originates from the subclavian artery and supplies the sternum and breasts before continuing after its bifurcation as the superior epigastric and musculophrenic arteries. Due to its limited length, the lima is usually only used for proximal disease. The lima to LAD is the most common type of graft. The lima can be harvested in several ways: pedicled, which includes the fascia, muscle, and veins; semi-skeletonized, which includes 2 accompanying veins; and skeletonized, which includes just the isolated artery. The skeletonized technique increases the effective length of the conduit available for grafting and avoids extensive deveining of the sternum, which allows for improved sternotomy wound healing. Therefore, skeletonized lima is associated with reduced risk of deep sternal wound infections, especially in patients who are prone to this complication. Now, how about the rema, the right internal mammary artery, and the radial artery, or RA? The radial artery originates from the bifurcation of the brachial artery in the antecubital fossa, running down the anterior forearm and ending in the deep palmar arch, where it joins with the deep branch of the ulnar artery. There's debate about whether the rema, also called the reta, or the radial artery should be the next best choice as the second arterial conduit for non-LAD coronary arteries after the lima to LAD. The radial artery has some shortcomings compared to the rema, such as the radial artery's susceptibility to vasospasm due to its thick muscular layer and intimal hyperplasia. The patency of the grafted radial artery is strongly influenced by the presence of competitive coronary flow. If the target vessel stenosis is under 70%, the lack of competitive flow from the native coronary artery will increase the rate of radial artery graft closure. Bilateral IMA prolongs surgery and makes healing slower. Use of the rema raises the risk of sternal complications in patients with diabetes, COPD, or obesity. If rema is chosen, the skeletonization technique would be preferred over the pedicle technique. The 2021 AHA-ACC SKY guideline for coronary artery revascularization says use of a radial artery is recommended in preference to a saphenous vein conduit to graft the second most important, significantly stenosed non-LAD vessel to improve long-term cardiac outcomes, and it gives it a Class 1A recommendation. Now, how about the right gastroepiploic artery, or RGEA? Also known as the right gastroomental artery, this RGEA is one of the two terminal branches of the gastroduodenal artery, running along the greater curvature of the stomach and eventually anastomosing with the left gastroepiploic artery from the splenic artery. The RGEA allows for revascularization using an arterial graft using the pedicle technique without additional aortic manipulation. However, harvest of the RGEA requires intra-abdominal entry, which may increase the rate of complications and operative time. Patency rates are not as high as the radial artery or the lima arema. The RGEA is rarely used, as is the inferior mesenteric artery, ulnar artery, and descending branch of the lateral femoral circumflex artery. Now, how about the saphenous vein graft? The great saphenous vein is a large subcutaneous superficial vein that returns blood from the deep femoral vein at the femoral triangle. Because it contains valves, it has to be used in a reverse direction when used as a coronary bypass graft. When you are hunting for SVGs on bypass graft angiography, from right to left, in terms of origin point from the aorta, are SVG to RPDA, then SVG to LAD, then SVG to diagonal, then SVG to OM would be on the leftmost. Harvested saphenous veins adapt to the higher arterial pressure from the aorta by remodeling and developing intimal hyperplasia with smooth muscle cell growth. Nevertheless, segments of the vein continue to have high susceptibility to atherosclerosis due to their wall structure, susceptibility to endothelial damage, and low production of nitric oxide. That's what we have for choice of conduit vessel in CABG. Now let's talk about a very important topic, the choice of CABG versus PCI in chronic coronary disease, previously referred to as stable ischemic heart disease or SIHD. Whether CABG or PCI improve survival compared to each other and compared to medical therapy in CCD or SIHD has been the subject of countless RCTs. There are several key populations, which we'll go over one by one. In patients with left main disease, many historic RCTs showed a survival advantage from CABG over medical therapy. No RCTs directly compared PCI with medical therapy, but a network meta-analysis in 2013 showed a survival advantage from PCI over medical therapy. All RCTs that compared CABG versus PCI show similar survival, except for one, Excel in 2019, that showed CABG was better. There was no head-to-head RCT that showed PCI had better survival than CABG. Accordingly, the 2021 ACC-AHA SKY guideline for coronary artery revascularization recommends CABG and makes an allowance for PCI. In patients with SIHD and significant left main stenosis, CABG is recommended to improve survival. That's a Class 1 recommendation. Note that this guideline came out in 2021 before the switch from the terminology SIHD to CCD. In selected patients with SIHD and significant left main stenosis, for whom PCI can provide equivalent revascularization to that possible with CABG, PCI is reasonable to improve survival. That's a class 2A recommendation. In other words, if you are presented with left main disease, either CABG or PCI is fair game as long as it is technically feasible. One is class 1 and the other is class 2A. Next, in patients with multi-vessel disease and reduced EF, Stitch showed that CABG was similar to medical therapy in survival, but Stitches showed that CABG has better survival than medical therapy. One RCT showed CABG is better than PCI. There are no RCTs that showed PCI is better than CABG or better than medical therapy. Accordingly, PCI is not even considered for this population in the official guidelines. The chest pain guidelines recommend CABG for LVEF less than 35% and less strongly recommend CABG for LVEF 35 to 50%. Let's hear their exact wording. In patients with SIHD and multi-vessel CAD appropriate for CABG with severe left ventricular systolic dysfunction defined as an LVEF less than 35%, CABG is recommended to improve survival. That's a class 1 recommendation. In selected patients with SIHD and multi-vessel CAD appropriate for CABG and mild to moderate left ventricular systolic dysfunction, EF 35 to 50%, CABG, to include a left internal mammary artery grafted LAD, is reasonable to improve survival. That's a class 2A recommendation. In other words, if you are presented with left main disease with reduced EF, the guidelines say to do CABG instead of PCI. It's just a matter of whether it is a class 1 or 2A recommendation for EF under 35 and EF 35 to 50% respectively. Next, in patients with multi-vessel disease and normal EF, it was historically assumed that revascularization improves survival in this population compared to medical therapy based on numerous old registries, an RCT from 1982, and a meta-analysis from 1994 that reported a survival advantage for CABG over medical therapy. However, the landmark ischemia trial in 2020 famously showed that there was no difference in survival between CABG and PCI. Based on the results of ischemia, the guidelines gave CABG a quote, may be reasonable, class 2B recommendation instead of a quote, is recommended, class 1 recommendation. With regard to the CABG versus PCI debate in this population of patients with multi-vessel disease and normal EF, several studies suggested CABG and PCI had similar survival. Some favored CABG and none favored PCI. Accordingly, the guidelines cast doubt on the usefulness of PCI in this population. In patients with SIHD, normal ejection fraction, significant stenosis in 3 major coronary arteries with or without proximal LAD disease, and anatomy suitable for CABG, CABG may be reasonable to improve survival. That's a class 2B recommendation. In patients with SIHD, normal ejection fraction, significant stenosis in 3 major coronary arteries with or without proximal LAD, and anatomy suitable for PCI, the usefulness of PCI to improve survival is uncertain. That's a class 2B recommendation. Next, in patients with multi-vessel disease and diabetes, the landmark Berry 2D trial showed no survival advantage of CABG or PCI over medical therapy, but was limited by the fact that enrollment and observed events both fell short of their intended targets. Accordingly, the guidelines take great care not to explicitly recommend revascularization, but couch the language of revascularization modality in terms of being applied to patients who are already deemed to be appropriate candidates for revascularization. In terms of CABG versus PCI in this population, several studies showed similar survival between CABG and PCI, but no studies have shown PCI to be superior than CABG in survival. Accordingly, the guidelines recommend CABG over PCI in patients with multi-vessel CAD and diabetes, unless they are deemed to be a poor candidate for surgery. Specifically, the guideline says, in patients with diabetes and multi-vessel CAD with involvement of the LAD who are appropriate candidates for CABG, CABG with a lima to the LAD is recommended in preference to PCI to reduce mortality and repeat revascularizations. That's a class 1 recommendation. In patients with diabetes who have multivessel CAD amenable to PCI and an indication for revascularization and are poor candidates for surgery, PCI can be useful to reduce long term ischemic outcomes. That's class 2A. In other words, when you are faced with multivessel disease and diabetes, CABG is a clear class 1 indication. But if the patient gets turned down by surgery, then PCI is still appropriate with a class 2A indication. Next, in patients with left main disease and diabetes, the guidelines also prefer CABG but make an allowance for PCI as a class 2B indication. They say, in patients with diabetes who have left main stenosis and low or intermediate complexity CAD in the rest of the coronary anatomy, PCI may be considered as an alternative to CABG to reduce major adverse cardiovascular outcomes, class 2B. Next, in patients with proximal LAD disease, a trove of RCTs showed that CABG and PCI are similar in survival in this population. However, there are only a handful of RCTs that showed any difference compared to medical therapy, and the results are mixed. Accordingly, the guidelines cast doubt on whether revascularization should be pursued in proximal LAD disease. They say in patients with SIHD, normal left ventricular ejection fraction, and significant stenosis in a proximal LAD, the usefulness of coronary revascularization to improve survival is uncertain, class 2B. Next, in patients with single vessel disease not involving the proximal LAD, there is no RCT showing a survival benefit to revascularizing. Accordingly, the guidelines recommend against it. In patients with SIHD, normal left ventricular ejection fraction, and one or two vessels CAD not involving the proximal LAD, coronary revascularization is not recommended to improve survival. That has a class 3 no benefit. In patients with SIHD who have at least one coronary arteries that are not anatomically or functionally significant, less than 70% diameter for a non-left main coronary artery stenosis, FFR more than 0.80, coronary revascularization should not be performed with the primary or sole intent to improve survival. Class 3 harm. Notice the way that these are worded. They say that it does not improve survival, but they still allow for the possibility of revascularization to improve patients' symptoms after shared decision making. There are a few other recommendations to touch upon. The guidelines note that for patients with complex disease, diffuse disease, or disease with high syntax score, CABG is preferred over PCI. Specifically, they say in patients who require revascularization for significant left main CAD with high complexity CAD, it is recommended to choose CABG over PCI to improve survival. In patients who require revascularization for multivessel CAD with complex or diffuse CAD, for example, a syntax score exceeding 33, it is reasonable to choose CABG over PCI to confer a survival advantage, class 2A. That being said, in situations where revascularization is not indicated for survival, and also in situations where revascularization is indicated for survival, revascularization can be pursued for improving anginal symptoms, as specified below. In patients with refractory angina despite medical therapy and with significant coronary artery stenosis amenable to revascularization, revascularization is recommended to improve symptoms, class 1. In patients with SIHD and multivessel CAD appropriate for either CABG or PCI, revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned urgent revascularizations, or cardiac death, class 2A. In patients with angina, but no anatomic or physiological criteria for revascularization, neither CABG nor PCI should be performed, class 3 harm. In general, patients who undergo PCI are more likely to have recurrent angina or require additional subsequent interventional procedures compared to patients who undergo CABG. If you cannot employ a lima to the LAD, that's a class 1A indication, then there is no point to doing CABG to the LAD because there will be no survival benefit. Calculation of the STS risk score is recommended in patients who are undergoing CABG, that's a 1B recommendation. But the STS risk score does not include frailty, malnutrition, and end-stage liver disease, so you have to keep that in mind. In conclusion, for all of what we discussed above, for left main disease, CABG for the majority, PCI for low risk anatomy patients, class 2A or surgical turndowns. For three vessel disease, you give CABG for those with low EF, less than 35%, and diabetes patients, class 1, and patients who have a complex disease with syntax score over 33, that's class 2A. You can do PCI for low risk triple vessel disease with a low syntax score, no diabetes, EF more than 50%, or if the patient declines CABG and prefers PCI. For two vessel disease, you can give PCI for the majority. CABG can only be done if you have complex multivessel disease of these two diseases involving the LAD, especially if there's low EF. For one vessel disease, you almost always PCI if it meets the appropriate PCI criteria, rather than doing CABG. Low EF and diabetes in general favor CABG. I hope that broke things down in a way that helps you decipher the thousands of trials out there investigating this CABG versus PCI topic that has been hotly debated, and that the answer to that question differs by what population you're looking at. So now we'll move on to pre-CABG management and prognosis. Before CABG, you can order carotid duplex ultrasound if the patient has any of the following: more than 65 years of age, history of smoking, history of stroke or TIA, history of PAD, carotid bruit, or left main coronary artery stenosis. In contrast to the carotid duplex ultrasound, an ABI to screen for lower extremity PAD is not routinely done before CABG. Atrial fibrillation develops in 40% of patients within 3 days of CABG and carries a 2 to 3-fold increased risk of postoperative stroke. Interestingly, up to 80% of patients with post-CABG AFib spontaneously revert to sinus rhythm within 24 hours with only rate control agents. Prophylactic use of beta blockers or amiodarone is appropriate to reduce the recurrence of post-op AFib. What does the 2021 AHA-ACC SKY guideline for coronary artery revascularization say about rate and rhythm medications in a peri-CABG period? In patients undergoing CABG who do not have a contraindication to beta blockers, the administration of beta blockers before surgery can be beneficial to reduce the incidence of postoperative atrial fibrillation. That's a class 2A recommendation. In patients undergoing CABG who do not have a contraindication to beta blockers, preoperative use of beta blockers may be effective in reducing in-hospital and 30-day mortality rates, class 2B. In patients undergoing CABG, the role of preoperative beta blockers for the prevention of acute postoperative myocardial ischemia, stroke, AKI, or ventricular arrhythmia is uncertain, class 2B. In patients undergoing CABG, preoperative amiodarone is reasonable to reduce the incidence of postoperative atrial fibrillation, class 2A. Now, what does the guideline say about antiplatelet therapy prior to CABG? In patients undergoing CABG who are already taking a daily aspirin preoperatively, it is recommended that they continue taking aspirin until the time to surgery to reduce ischemic events. That's a class 1 recommendation. That part's easy. In patients referred for urgent CABG, clopidogrel and ticagrelor should be discontinued for at least 24 hours before the surgery to reduce major bleeding complications. Class 1. In patients undergoing elective CABG who receive P2Y12 inhibitor before surgery, it is reasonable to discontinue clopidogrel for 5 days, ticagrelor for 3 days, and prasugrel for 7 days before CABG to reduce the risk of major bleeding and blood product transfusion, class 2A. In patients undergoing CABG, discontinuation of short-acting glycoprotein 2B3A inhibitors such as eptifibatide and tirofiban for 4 hours and abscizumab for 12 hours before surgery is recommended to reduce the risk of bleeding and transfusion, class 1. In patients undergoing elective CABG who are not already taking aspirin, the initiation of aspirin 100 to 300 milligrams daily in the immediate preoperative period within 24 hours before surgery is not recommended. Class 3, no benefit. Now we can move on to post-CABG management. What does the CABG versus medical therapy survival curve look like? There's an early hazard. The patient has to survive the CTICU course in order to derive benefit from CABG. There is an intermediate term, 2 to 10 year survival benefit to CABG. But eventually, the CABG and medical therapy curves merge due to long term risk of graft closure. Over the years, the rate of perioperative complications from CABG has increased because of the increasing complexity of cases which are being referred to CABG instead of PCI. However, the in hospital mortality after isolated CABG has improved from 3% in the mid 1990s to 2% in the mid 2010s. The incidence of kidney failure requiring dialysis after CABG is low at 0.5 to 1.0%, but has greater morbidity and mortality when it occurs. More than 50% of patients who undergo CABG have short term cognitive decline at the time of hospital discharge. The rate of post CABG stroke is 1.5 to 5.0%. Cerebrovascular complications after CABG can occur via atherosclerotic cerebral emboli from the aorta, emboli related to the cardiopulmonary bypass machine, and intraoperative hypotension. Let's talk about peri-CABG MI. Perioperative MI during or after CABG occurs in 3% of CABG cases. It is difficult to diagnose because most patients are sedated and may not sense ischemic cardiac pain, and those who are not sedated may have difficulty distinguishing ischemic myocardial pain from sternotomy related pain and pericarditis related pain. Troponin is always going to be elevated as a result of myocardial incisions made for cardiopulmonary bypass. The ECG may not be diagnostic because diffuse SC segment abnormalities are very common after CABG. However, if there are new SC segment elevations in a focal area that are not diffused across leads, then there should be concern for acute graft failure or spasm. The most reliable ECG finding of post-CABG MI is new and persistent Q waves. Since all CABG patients will have elevated troponin post-surgery, the fourth universal definition of MI defined post-CABG MI as an elevation in cardiac troponin to no more than 10 times the 99th percentile upper reference limit in the presence of to more than 10 times in the presence of other clinical findings that support new MI, such as new pathologic Q waves or new local ST elevations, angiographic evidence of new coronary or bypass graft occlusion, and or imaging evidence of a newly infarcted myocardial therapy. CABG patients will have paradoxical septal motion for at least several months after cardiac surgery. Risk factors for CABG MI are older age, longer cardiopulmonary bypass time, elevated LV end diastolic pressure, preoperative unstable angina, and significant left main disease. We should also know something about sternal wound infections. Deep sternal wound infections present 2 weeks post CABG with fever, leukocytosis, bacteremia, discharge, and erythema at the sternotomy wound site. Risk factors for developing deep sternal wound infections are prolonged cardiopulmonary bypass time, excessive bleeding necessitating re-exploration for hemostatic control, use of bilateral internal mammary arteries instead of just the lima, older age, obesity, diabetes mellitus, and preoperative atrial fibrillation. These are risk factors for developing deep sternal wound infections. Half of deep sternal wound infections are caused by staph, and 40% are caused by gram-negative organisms. Sternal wound infection requires surgical exploration and removal of infected material for culture, plus prolonged antibiotics. But interestingly, the development of mediastinal infection does not change the patency rates of the bypass grafts. Obesity is the largest risk factor for development of sternal dehiscence, whether or not sternal infection is present. What should you do for antiplatelet therapy after CABG? According to the 2021 Coronary Artery Revascularization Guidelines, in patients undergoing CABG, aspirin at 100 to 325 milligrams daily should be initiated within 6 hours post-operatively and then continued indefinitely to reduce the occurrence of SVG closure and adverse cardiovascular events. That's a class 1 recommendation. In selected patients undergoing CABG, adapt with aspirin and ticagrelor or clopidogrel for 1 year may be reasonable to improve vein graft patency compared with aspirin alone. That's class 2B. That's all for CABG revascularization. We have talked about choice of conduit vessel for CABG, including arterial versus venous grafts, choice of CABG versus PCI in chronic coronary disease in different populations, pre-CABG management, and post-CABG management.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.